Hello, everybody. I'm Abe Morgenthaler, and I'd like to welcome you to this AReA educational webinar. The title today of our topic is the Testosterone Trials, Translating the Science into Clinical Practice. I'm an associate professor at Harvard Medical School in urology in Boston, but I happen to spend most of my time now in Sarasota, Florida, and managed to survive Hurricane Ian, which you may have heard about, and we held on to our power. So I'm delighted to be with you here live. We had recorded some stuff, but it's always better live. I want to thank Bessens or Bessin for organizing this and sponsoring this educational event. We have really a paucity of training and education in the testosterone area. And these events have been marvelous as a series, and today is going to be outstanding with our speaker, Jeff Hackett, addressing the testosterone trials. I just want to go back for a second, and I just want to share with you that for those of you who like to attend an educational event live, I'm giving this Harvard Medical School course in Orlando, Florida in February on testosterone therapy and sexual dysfunction. It'd be marvelous if any of you wanted to join us there. These are my disclosures. What is AReA? It's an educational platform that provides a forum for educational exchange. It highlights the latest research in the field of andrology and fosters interactions with international experts, and today is an example of what we're doing. The aim of this particular webinar is to revisit and refresh your knowledge and understanding of the T-trials or the testosterone trials, to offer ideas on how the results should be interpreted and applied in daily practice, to optimize the management and care of patients. This is a disclaimer for the program that I think you've all seen already. And just some practical points. Your screen can appear in two different modes. If you've got this smaller mode and you want to enlarge it, you click on those arrows and you get this gorgeous view. Here is Dr. Hugh Jones and Dr. Mary Simplasky. But if you want to participate in the chat or the question area, you have to go back and hit escape if you're in the large view. So your screen will look like this. So this part here will shrink, and then you'll see on the right-hand side the area where you can write in your questions. Evaluation and feedback is very important for us in order to make our programs better and better. There should be a button that you can see that says evaluation form at the end of the activity. Please click on it, and then subsequently you'll receive your certificate of attendance. So our agenda today is really one thing, which is that Jeff Hackett is going to be talking to you about the testosterone trials. Jeff Hackett is a dear friend and colleague. We go back as warriors in the testosterone field for probably about 2 decades at this point. Jeff is a professor of men's health at the Aston University Medical School. He was the chairman of the British Society of Sexual Medicine. He's been in private practice for over 30 years. He's published 160 papers, 4 textbooks, book chapters. But the real reason I'm so delighted to have Jeff speak and honored to be the person introducing him is that Jeff has a particularly incisive mind. And you've heard of the fog of war. I believe that we also have something equivalent, which I might call the fog of medicine, where there's a lot of information or attitudes and beliefs that we're taught and trained. And sometimes the actual evidence is contradictory to all that. And Jeff has the particular gift of being able to see through and see what actually is true and not what we've just been taught. And I think you'll get a full flavor of that in a moment when Jeff gives his comments. I also want to give a shout out to Jeff Hackett. He has a new book that's out called Testosterone and Cardiometabolic and Other Diseases. And congratulations to Jeff on that. And you may want to purchase that. Um, I'm going to take just a couple of moments to provide a little context as I see it, a little history, if you will, for the testosterone trials. You know, we have this balancing act that is challenging, at least for me, which is that we have a lot of evidence around testosterone therapy that shows a variety of well-documented, well-supported benefits in the literature. And yet we have overall in the medical community and certainly in the public, a rather negative or dismissive attitude about testosterone therapy. And the question is, how does that happen? How did that happen? And the history gives very quickly a little bit of a clue about this. And so, you know, testosterone was first synthesized in the mid 1930s. And by 1940, in the New England Journal of Medicine, came this article by Joseph Obb that was really laudatory about the benefits of testosterone. I know it's small print there, but the author writes, indeed, in my experience, this is one of the most potent drugs, testosterone, recently introduced to medicine. And he goes on to talk about its use in hypogonadism, how some of these men had erections that occurred almost immediately. The small prostates in these men grew back to normal size. And perhaps most importantly, he writes, greater psychological assurance and vigor are obvious. That was 1940. What happened in 1941? 1941, Charles Huggins and his co-author published a paper that suggested that testosterone, well, I'll read the bottom. The final sentence of this paper is cancer of the prostate is activated by androgen injections. They were the first to figure out that castration or lowering testosterone could be beneficial for men with metastatic prostate cancer. And for the next 50 years, the world was afraid to give any testosterone, believing it would cause prostate cancer or make a hidden prostate cancer grow like wildfire. And so there was very little testosterone therapy given for half a century or longer. Amazing. In the late 1990s and the very beginning of this century came this idea that observation that was well recognized that men in their middle years and older developed this syndrome, if you will, or a set of symptoms where there was a decline in health. They got lower sex drive. They felt fatigue, lack of energy, some malaise or depression. And doctors came up with an analogous term to menopause, and they called it andropause. And many of the leading figures in urology, sexual medicine, but also the largest figures in the world of endocrinology were totally on board with the idea that this was an important thing and we needed to help these poor men. And testosterone therapy was an acceptable way to do that. There was a lot of enthusiasm for it. Some of the same voices that today are terribly dismissive about testosterone were totally on the bandwagon about let's do this and help men. That was around 2000, 2001, if you will. And what happened in 2002 was the publication of the Women's Health Initiative study, or at least the first publication, that got tremendous publicity around the world and suggested that there were these surprise risks to hormone replacement therapy that was widely used in women, including breast cancer. Now, this has since been reassessed, but for a generation, for about 20 years, the use of HRT in women went down by something like 90%. And this had an effect also on the field of testosterone for men, because at least what people argued is at least it was studied in women. Testosterone hadn't even been studied in a long-term large study for men. And so this was a concern around testosterone too. And then in 2013, 2014 came again a surprise study about testosterone suggesting that there were cardiovascular risks. Again, huge publicity around this in the media and the public. And many doctors learn about medicine outside of their field the same way the public does, which is basically through public media. And this was scary for people, and rates of testosterone prescriptions dropped also around 80, 90%, just like it had for the women. And so as we came to 2016, when the testosterone trials were, the first publication came out, where the field was that we had a rather impressive number, in my opinion, of small to moderate control trials that had shown multiple benefits for testosterone. We had reassuring evidence that the risks that everybody spoke about, like prostate cancer and cardiovascular disease, did not appear to be true, and yet we had this criticism of the field, which people said all the time. They said, "Listen, we don't have yet a large prospective study like the Women's Health Initiative study, and we don't know if these benefits will hold up. Let's see what happens if a large multi-center study got published." And of course, that was the testosterone trials. Now, Dr. Hackett's going to present to you the results of that study as he sees them. But I think it's fair to say that for many of us, that was a nice confirmation of those small to moderate sized trials. It showed what we thought and expected testosterone to show. But that's not how the trial, or the results of the trial, was described. This is a quote from members of the FDA panel that oversee testosterone products in the United States. And in an opinion piece that they published last year in Androgens, referring to the testosterone trials, they wrote, "For most of these measures, the publications reported no improvement with testosterone therapies, and for others, the results were of uncertain clinical benefit." I'm going to leave it to Dr. Hackett and to your open minds as to whether or not that kind of conclusion is accurate. And without further ado, I'm going to turn this over to Dr. Hackett. Thank you all for being here.
Thanks very much for the kind introduction, Abe. My job today is to talk about the testosterone trials translating the science into clinical practice. The testosterone trials were published in the New England Journal of Medicine in 2016, entitled "The Effects of Testosterone Treatment in Older Men." In fact, there were 7 trials in one, and this was a trial that was many years in evolution. As you can see, it first started in 2002, and the trial actually took place between 2016 and 2017. There were 7 components to the trial, and at the end, I'll give you my theory as to how this fits into what I call the heptathlon effect of testosterone. So there was a sexual function trial, the physical function trial, the vitality trial, the cognitive function study, the anemia study, and the cardiovascular and the bone studies. And as you can see, there were different numbers in each group because they were effect trials within trials. So there were 7 trials at 12 US sites. 790 men entered the studies, and the criteria were a baseline testosterone level and a morning fasting sample of less than 9.5 nanomoles per liter. The participants were randomized to either receive 1% testosterone gel as Androgel in a pump dispenser, which corresponded to 5 grams per day, adjusting them to the normal testosterone levels for a healthy young man. The other half received placebo gel for 12 months. There was an allocation by minimization, which was designed to minimize the large number of possible variables within this stratified group. And these included randomizing according to testosterone level, and non-use of various medications, such as antidepressants or PDE5 inhibitors. So they started out with over 50,000 men, a very large number, and by subsequent screening, which took into account eligibility according to criteria, past history of prostate cancer or other diseases, or a few patients who declined to take part, at further screening processes, we arrived at the final number of 790 patients, and 395 were randomized to each group. So let's break down the 7 components and look at them individually. First of all, let's look at the sexual function trial, which was designed to study the effect of testosterone therapy on sexual activity in older men. There were 459 men enrolled in this part of the study, with a mean age of 72, 89% were white, and 8.4 were using a PDE5 inhibitor, and that was allowed to be continued to be used in the same way throughout the study. The first thing to see from the serum levels was that these patients achieved the normal range of testosterone, both total testosterone and free testosterone, and there was also an increase in estradiol, and as you can see, the differences between testosterone treated group and the placebo group. The sexual function part of the study was assessed by a criteria, the PDQ-4, which is one that most of the audience probably won't be aware of. And in fact, I had to go back and look this up. And in fact, it consists of 54 questions, and really only one relates directly to sexual activity. And the possible answers were either not me, somewhat me, or that's me. So these will be results that we're not commonly used to. But as you can see, both in the 459 men who were in the sexual function trial and in the whole group of 771, there was a significant improvement in the baseline question on sexual function. If we go on to something that we're much more familiar with, those of us who practice in sexual medicine, we found that there was an increase in sexual interest and sexual activity. And in fact, couples on testosterone therapy engaged in sexual activity 4 times per week, which I thought was interesting to be described by the authors as a modest response. I hate to think what level of sexual activity would have been described as a highly significant response. There was also an increase in the level of sexual desire for active treatment compared with placebo. And there was also an improvement in the IIEF-5, the short version of the IIEF to assess erectile function. But I point out that it was 2.6 points versus placebo. And the important thing about that is that as these men had moderate to severe erectile dysfunction, this level of improvement over a 12-month period is unlikely to result in resolution of erectile dysfunction. If we compare this with another recently published study, which is the T4DM study, which came from Australia, which involved 1,007 men with type 2 diabetes who were randomized to either placebo injection or placebo nebido, you will see here that there was also a 2-point improvement in EF score, but the erectile function actually got worse on the placebo over the 2 years. So the actual response in terms of active therapy was only 1 point. You will see that there was also improvement in orgasmic score, sexual desire, intercourse satisfaction, and overall satisfaction, as well as improvement in body composition, as shown on the left. The interesting thing is that there was reduced sexual function in the placebo arm of this study, despite intensive lifestyle intervention. The patients were allocated to an active lifestyle modification program, including membership of Weight Watchers. So moving on to the physical function trial, the standard here was the effect of testosterone therapy on the 6-minute walking distance in this group of older men. And as you can see here, there were 387 men enrolled in this part of the study. And it was to determine if testosterone therapy increased the 6-minute walking distance beyond 50 meters from the baseline level. This is the standard accepted significant improvement. Once again, these men were round about 72, 89% were white, and the average gait speed at the start of the study was 1.1 meter per second, which shows that they were significantly impaired. And if you look at the results of the testosterone therapy versus placebo, you will see that in both groups, the men who were enrolled in this specific part of the study, plus the entire group of 788 men, there was an improvement in the 6-minute walking test. It was more marked when the whole group were included, which suggested that we needed the whole 778 to get powerful results at the end. And there was a suggestion that the patients were still improving by the end of the 12 months. And what it meant in reality was that 20% of the treated patients improved their walking distance in 6 minutes by greater than 50 meters, compared with 10% in the placebo arm. The placebo response is likely to be due to the fact that these men had been relatively inactive before, and any activity that actually got them up and moving more regularly was going to result in some improvement. If we now move on to the vitality study, this was the effect of testosterone therapy on vitality and fatigue in older men. There was 474 men in this part, and once again, mean age 72, 89% white, and they had a facet fatigue score at the beginning, a mean of 36.9, which meant they had significant effect on vitality and fatigue. The next part of the study was the vitality trial, which looked at the effect of testosterone therapy on vitality, mood, and depressive symptoms. This resulted in modest improvement in vitality, mood, and depressive symptoms, which versus placebo, which was more significant when the entire group of 788 men were included. But there has been doubt cast on the significance of these findings because the improvements were at best modest. Moving on to the cognitive function trial, looking at memory and cognition in older men. This involved 493 men, and once again, you'll see the baseline demographics were similar. And they had a significant degree of mental impairment as assessed by the mini mental state examination with a score of 92 at baseline. When we look at the breakdown here, the conclusion was that testosterone therapy did not improve memory or other cognitive functions in older men. The one thing that did improve significantly was executive function. Now, this is evaluated by two main tests, and I know quite a bit about these because I had to undergo these when I was recently discharged after a lengthy hospital admission with COVID, which involved 6 weeks in intensive care and being ventilated. And they include the Stroop test and the Maze test. The Stroop test is a test where against the clock, subjects are given a number, and the number is written in different colors. And then you get colors written in different colors. And the trick is to be able to identify the difference between whether you're seeing the number in one color or another. So it involves a particular executive function that is highly susceptible to things like COVID infection. And interestingly enough, I passed the Stroop test, but I failed the second one, which is the Maze test. Now, this consists of finding your way out of a complex maze within a period of time. And this I found quite demanding at the time, but this did improve in subjects within the T trials. The anemia trial was perhaps the most positive finding of the T trial overall. This was the relationship between testosterone levels and anemia and its impact in older men. There were only 126 patients with anemia, which represented 16% of the overall group. And in 62 of these 126, the patients were diagnosed as having unexplained anemia. In other words, this had not been detected with previous tests, and the patients were therefore not on any previous treatment. One could debate whether it was only an unexplained anemia because nobody had measured the testosterone previously, and had they measured the testosterone, then a possible explanation would have been determined. These were slightly older at 74.8, and 85% were white, and the mean BMI was 30.7. In the study, testosterone therapy significantly increased hemoglobin levels in older men, both with explained and unexplained anemia. As you can see here, this is the group with unexplained anemia, and as you can see, round about 60% of men improved their testosterone level by more than 1 point from baseline. And on the right, you'll see the changes in hemoglobin from baseline, and as you can see, the mean change was round about 1 point, and of course there was no improvement in anemia on the placebo group. If we move on to the men with anemia of known cause at baseline, you can see a similar effect, round about 50% improving, and the change in hemoglobin once again was about 1%. And if you look at the association in men without anemia, there was even an increase in hemoglobin in 40% of men treated with testosterone in those who had normal hemoglobin levels at baseline. And as you can see, the overall increase was about 0.5 total in the hemoglobin. And this is important because this shows us why men with testosterone deficiency treated with testosterone get a rise in hematocrit, which can be one of the slight concerns when patients are treated for prolonged periods with testosterone therapy. If we move on to the cardiovascular trial, this is perhaps the most contentious arm of the study. This was designed to look at the effect of testosterone therapy on coronary artery plaque volume in older men. There were 170 men enrolled in this, and 138 completed the trial. Mean age was 71, 81% were white, and there was severe atherosclerosis in 50.7%, which is defined by a plaque burden of over 300 millimeters. The most important thing about this study, which has caused most concern, is that there was a significant baseline difference in plaque volume between the two groups. For example, it was 204 millimeters in the testosterone-treated group and 317 millimeters in the placebo group. And when you look at the rate of increase, this effectively means that it would have taken 3 years for the baseline group in the testosterone arm to have reached the baseline group in the placebo arm. And there are always doubts cast on a study where randomization results in such a significant difference in baseline. For example, if we were looking at the change in weight, and one group had a weight of 80 kilograms and the other one had a weight of 120 kilograms at baseline, some would look at a study like this and say that we were looking at 2 completely different cohorts of patient. But what was found was that the testosterone treated group increased from 204 to 232 millimeters, and the placebo from 317 to 325. And as I've said, this would have resulted in nearly 4 years from the testosterone group to have reached the baseline for the placebo group. So in this study, it was hardly likely to transform into any actual cardiovascular events. there is a lot of doubt as to what the significance of non-calcified coronary artery plaque means in terms of cardiovascular risk. And the conclusions were that this really needs to be conducted again in a larger study, probably with better matching of the two cohorts. Moving on to the bone trial, this looked at the effect on bone mineral density in older men, and there were 211 patients in this group, and once again, similar mean age and ethnic distribution. The conclusions here were that testosterone therapy significantly increased volumetric bone mineral density and bone strength, and that the improvements were most marked in the spine rather than the hip. It increased the bone mineral density by an additional 6.8% and the spine trabecular bone strength by 8.5%. And for those who don't know what this means in relation to other possible treatments, this is about the same rate as you would get in patients who are using bisphosphonates. And if we remember that these patients weren't specifically chosen because they had a high level of osteoporosis, but this was a highly significant finding from the study. One part of the study that wasn't originally reported, but was reported in a similar, in a paper published later, were the changes in glycemic control from baseline. This was a paper written by Moeller in 2018. 30% of the patients in the study had type 2 diabetes. And as you can see from the left in blue, the testosterone therapy was associated with a reduction in insulin level over the 12-month period, whereas in the placebo arm, insulin levels increased. There was also a slight reduction in the HOMA-IR in the testosterone-treated group, but note that these patients had normal levels of HOMA-IR and HbA1c because only 30% of the patients had type 2 diabetes. And one of the interesting things about this was that the authors reported no effect on patients not on diabetes medication, but did not analyze the subgroup of patients who were on diabetes medication, who would have been likely, based on the findings of the entire group, to have shown an element of improvement in diabetes parameters. So what about the safety profiles in this group? We had a large number of men treated with either testosterone or placebo for a 12-month period. Well, in terms of prostate events, there was an increase in PSA level. 23 patients increased their PSA level beyond what would be regarded as the normal range versus 8 in the placebo group. But only one case of prostate cancer was detected over the entire treatment period. There was an increase in IPSS, and this was shown in the T4DM study, and we would have expected it in a group of men of this age. And as you can see, 7 patients out of the 395 in the testosterone-treated group had an elevated hemoglobin that went over the level that we would be concerned about, 175 grams per deciliter, or a hematocrit of 54%. In terms of cardiovascular events, there were really no significant issues here, with 2 myocardial infarctions in the treated group, 1 in the placebo arm, and no deaths in the testosterone group, which is very reassuring, and 1 in the placebo arm. When we look at other events, overall deaths were lower in the testosterone-treated group, 3 versus 7. But again, this study wasn't really powered for that as an outcome, and a slight decrease in hospitalization, which was reassuring in the testosterone-treated group. I'd just like to mention some findings from my own study here. This was the BLAST study, which we published in 2019. And this was a study of 857 men in UK general practice who all had type 2 diabetes, and they were screened for testosterone deficiency, and they were randomized to either placebo or testosterone long-acting injection under canoate as part of a double-blind placebo-controlled study. And as you can see on the left, out of the 857, the cutoff was a total testosterone of greater than 12 nanomoles per litre was regarded as normal, and below 12 was regarded as suggestive of testosterone deficiency. And as you can see, with 537 men being less than 12 nanomoles per litre, this equated to a 60% prevalence of low testosterone in this group of primary care diabetes patients. Of those with low testosterone, 175 patients received testosterone therapy either in the 6-month double-blind part of the study or the 12 months open label, versus 362 men who remain untreated, not on testosterone therapy at any stage. And these men were followed up for 4 years. At the end of 4 years, there were 78 men who continued testosterone therapy till the end, and there were 97 who discontinued testosterone. And the major reason for this was that testosterone therapy was only provided for 12 months of the open label extension, and therefore there was pressure upon the practices and the patients to fund the testosterone therapy themselves beyond that stage. But that's still a very good continuation rate in patients who stayed on the treatment for 4 years. And what we found here in the highlighted section here, if we look at these two groups, 2B1 and 2B2, the patients who remained on the testosterone therapy for the 4 years had a much higher rate of taking PD5 inhibitors. More than 53% of patients took a PD5 inhibitor throughout that time. And if you remember from the T trial, the use of PD5 inhibitors was only 8%. And if you look at the mortality rates at the bottom, you will see that in the group of patients with normal testosterone, the mortality was 11.3% over the 4 years. In the group with low testosterone, the mortality rate was 16.3%. So in other words, a lower testosterone in type 2 diabetes was associated with increased mortality over 4 years. In the treated group, the mortality overall was only 6.2%. And not a single patient who remained on the testosterone therapy for 4 years actually died. And this was very reassuring, given that this was a group of high-risk men with type 2 diabetes. And when we put this into graphical figures, here is as you can see in blue, is the mortality over time in the testosterone versus the untreated group, and it's much lower. But when you look at the men who both took testosterone, took a PD5 inhibitor, and took a statin, the mortality was greatly reduced. Now, how have these findings from the T trial manifested themselves in guidelines? Now, the point I'd like to make here is that there's a tremendous difference between guidelines that are devised by endocrinologists versus those devised by urologists. And these are the guidelines for the Society for Endocrinology in the UK. And as you can see, their clinical suspicion for low testosterone are patients with new sexual symptoms, unexplained anemia, low bone mineral density, and various conditions that predispose, such as orchidectomy, Klinefelter syndrome, and other genetic causes, and radiotherapy. And as you can see, their cutoff is 12 nanomoles per litre being suspicious, and less than 8 nanomoles per litre being highly suspicious and indicating treatment. One of the interesting findings of this is that, being endocrinologists, they advise against the need for patients to have a digital rectal examination either at the beginning or throughout the treatment period. And they actually make the comment that endocrinologists are not good at digital rectal examinations, and actually say that it might be harmful. If you compare that with the European Association of Urology guidelines, as published here, you can see that the urologists recommend 3 digital rectal examinations in the first 12 months. So you can see here that here's an immediate Brexit effects where European patients with hypogonadism get 3 digital rectal examinations a year, and in the UK they get none, particularly if they see an endocrinologist. So what are the conclusions we can draw from the T trials? This was a paper that looked at the long-term data, and it was published in 2021 by Shelley Basheen, who was one of the lead authors and instigators of the T trial. And what were the conclusions and the take-home messages that they made from this study? Testosterone treatment of older men with low testosterone levels improves overall sexual activity, sexual desire, erectile function, improves volumetric bone density, estimated bone strength in the spine and the hip, corrects unexplained anemia of aging, increases skeletal mass of the muscles, muscle strength and power, self-reported mobility, and some measures of physical function, and modestly improves depressive symptoms. Now, if you look at that counselling that given to a patient, if I was a patient and was told that testosterone therapy might be associated with all those benefits, wouldn't I choose to take testosterone therapy if my testosterone level was low? They then go on to say the long-term effects of testosterone on major cardiovascular events and prostate cancer risk remain unclear. The problem is that what do we say to patients when we say that we've thoroughly counselled them? This is the level of counselling that I traditionally give to patients, but I see some patients where the only counselling that they received was that the testosterone therapy might be bad for their heart or their prostate. Well, I don't really feel that that is balanced counselling. So what are our take-home messages from the T trial? T trial involving 1% gel given for 1 year to older men with low testosterone moderately improved all aspects of sexual function, improved walking distance by a small amount, improved hemoglobin levels and corrected mild to moderate anemia, markedly improved volumetric bone mineral density and estimated bone strength, did not significantly improve vitality, but mildly improved mood and depressive symptoms, did not significantly improve memory or cognitive function, increased coronary artery plaque volume, but the groups were non-comparable and the findings of this were questionable, was not associated with more cardiovascular or prostate adverse events. However, the numbers of men and the duration of treatment were insufficient to draw definitive conclusions about the risks and safety of testosterone in this regard. And I'd like to leave you with a point that I made earlier. These were 7 different studies in one, and this is what I called the heptathlon effect. Because if you look at the 7 components of the T trials, there were modest improvements in some, little improvement in others, but the overall effects were significantly beneficial. If you send a patient to a specialist, for example, who is solely concerned with the bones, he is only going to advise treatment on what is best for your bones. So he might conclude that a bisphosphonate might be more efficacious than testosterone therapy. But this is rather like the heptathlete, or on the right-hand side, the decathlete in terms of men, whereby these athletes would not have been selected for their countries. And I shamelessly show two of the greatest British athletes here, Jessica Ennis and Daley Thompson. They would not have been selected for any of the events individually. They wouldn't have ever been Olympians. But because they were selected for an event that was over 10 different events, they became acknowledged as two of the greatest world athletes of all time. And I think if we begin to think in these terms, we can see how testosterone therapy can be beneficial for our patients across a whole range of important health topics. Thank you very much.
Well, Jeff, that was an outstanding presentation, and I loved your final slide and with the heptathlon and the idea of the different events. Here's my question for you. So, I showed a slide just before you began your presentation from an opinion piece from the FDA, group of authors from the FDA, that really minimized the results of the testosterone trial. That's not an unusual position for a lot of physicians and even some of the experts in the field. And yet you also showed that marvelous summary of the abstract by the paper of Dos Santos and Bassin at the end that listed all these wonderful benefits of testosterone from their review of the literature. How do you make sense of these two different kinds of streams of thought, if you will?
I think it's due to the fact that we work within narrow specialisms. If I could give you another example, if there was a paper recently that showed that if you have BPH, that daily tadalafil is similar to an alpha blocker in terms of LUT symptoms. But there's a world of difference in what's going to happen to your erectile function. The alpha blocker won't improve your ED. The daily tadalafil will probably normalize your ED. If you don't have a discussion, if you have a blinkered effect and say, I'm a urologist who deals with the prostate, and you never ask about their erections, you'll probably prescribe the alpha blocker because you're more familiar with it, it's much cheaper, but you're not treating the patient to their best interest. Because once you mentioned that, do you have erectile dysfunction, and you offer a patient a drug that will normalize two major problems in their life, it's a no-brainer for that patient. And the whole thing about this is that we're sending people to individual specialists who can't see the bigger picture, which is really the patient's quality of life.
Very good. Well, we have a number of questions that are coming up on my little app here. So let's go through them. We'll get to as many of your questions as we can here. What do you think about the use of testosterone in young men who have borderline low testosterone levels?
Well, I think the problem with younger men is we probably have to look more for a reason why they might have low testosterone levels. For example, what they might have been taking, might they have been taking drugs for sporting enhancement, etc. And of course, we have the major problem of testosterone affecting future fertility. So I think it's very important to work out whether it's primary or secondary hypergonadism. And most cases will be secondary with a low LH. And I think in these, we need to look more readily at preserving the fertility and perhaps using drugs like HCG or clomiphene or newer derivatives of clomiphene or even an anastrozole if they've got raised estradiol levels. And even in some cases, I off-label combine a small dose of testosterone with the other drug to try and preserve fertility if these patients are going to need treatment long term.
Yes. I recently saw grand rounds by a very distinguished endocrinologist about testosterone therapy. And mainly he focused on the risks and how much was not known. And really, I don't think he even went through the benefits of testosterone. And at the end, I asked a question. I said, clearly different specialties may have different attitudes about testosterone therapy or TRT. Who would you treat? And where he took it was, well, hold on, I'm going to ask you to comment on this. And what he didn't talk about who he would treat. What he specifically said was another case where he'd be reluctant to treat, which was the younger man who had low levels of testosterone. He said, I would hate to condemn him to a lifetime of testosterone therapy. Can you comment on that?
Well, the trouble is in that he's also condemning him to a possible lifetime of testosterone deficiency and hypogonadism, which in a lot of cases you see men who've been unable to form any relationships or have any sexual activity. And they are also often underachieving in their work and their life in general. And they usually have to have pretty grim symptoms before, particularly in the UK, they ever get anywhere near a clinician. They probably suffer for several years and the best part of their life has passed them by. Of course, we've always got to address lifestyle issues because a number of these men will be obese and have unhealthy lifestyles. But when you actually look at the evidence for lifestyle intervention, the EMAS study, for example, showed that you had to lose 20% of your body weight before you got a significant improvement in your free testosterone level. Well, the trouble is that sending guys away to do that is probably like sending them into the wilderness because the results, the society is getting fatter, not thinner, year by year. So I think we have to be practical rather than going on this evangelical approach, which is the one that a lot of endocrinologists follow.
Here's a question about the testosterone trials in anemia. There was a very impressive improvement in hemoglobin or hematocrit, as you nicely showed. And the question is, should checking a testosterone level be considered part of the routine workup for men with anemia?
Yes, and there's several papers on this. A good one by Richard Quinton in the UK entitled Hiding in Plain Sight, where he picked up prevalence rates on routine hospital admissions of about 20%. And, as I said earlier, it's only an undiagnosed cause of anemia if you haven't considered it. And we can make a huge difference in these patients' lives, but we're obsessed with the raised hematocrit being a negative, whereas you actually can make 20% of the patients much better by normalizing their hemoglobin levels. And hemoglobin is a risk factor for cardiovascular disease.
Right. Here's a question that may have some personal meaning for you. Is there any study about COVID-19 infection and testosterone levels? And does increased testosterone bring about any benefits with COVID-19 infection?
Absolutely. I wondered if this came from Janine in the UK, because in fact, even before I got ill, we'd done a study in the Midlands in the UK, and we looked at round about 100 acute admissions. And we found that the mean testosterone level on admission with acute COVID was 3.9 nanomoles per litre. And if you were below that level, you were twice as likely to die. And several studies have seen this. There's one from Italy, for example, that followed patients up for 12 months, and they found that even in those who survived, 50% was still hypogonadal 9 months later, and 10% were actually worse than they had been on admission. So there's no doubt that there's this issue about survival, and there's also the issue about long-term disability. And only recently I saw a patient who was a doctor who'd caught COVID, and 9 months later, he was still suffering severe symptoms. And he was, although his hospital was sympathetic when he was initially ill, now 9 months later, they actually wanted him out the door and retired because he was 56 years old. And I did his testosterone level, and it was 2 nanomoles per liter. And 4 weeks later, he was back at work. And it makes you wonder how many men there are going around the long COVID clinics. And when I attended my long COVID clinic, I said to my specialist, who was actually an immunologist, when are you going to measure my testosterone level? And he said, why would we do that? So I said, well, you haven't asked me about erectile dysfunction during my 3-hour visit. And he said, well, we assumed that if you had a problem, you would have told us. And I said, well, yes, I would, but 99% of men wouldn't do, but it's what I live for. That's why I'm going to discuss it with you. So that's the sort of problem that we have. Very good.
Can you comment on the use of calculated testosterone as a laboratory measurement versus total testosterone, and what do you do, and what do you see as the benefits of one over the other?
Yeah, well, guidelines have traditionally said just measure total testosterone first of all, and then if it's low or borderline, when you do a repeat, do the SHBG and calculated free testosterone. You can see the logic behind that, because we don't want to make it too complicated at first. But the sort of patients you've got to think about are that the obese patients tend to have low SHBGs. So therefore, they might have a lowish or low normal total testosterone. And because of their low SHBG, secondary to the obesity, they will have a reasonable free testosterone. So that gives you a good logic for not treating that person with testosterone, to look at getting some weight reduction. So that's actually a positive reason for doing an SHBG and calculated free testosterone, because you might save unnecessary prescribing of testosterone therapy. Conversely, you can have an older patient who's got reasons why they have a highly elevated SHBG. And I saw a patient recently with an SHBG of 175. And that could be due to liver disease or multiple drugs that can put the SHBG up, anticonvulsants, etc. So these are the types of patients where you need to think about the importance of the SHBG. And I think we need to amend the guidelines to do it actually routinely at that first visit.
Yes. I would just add a comment that, for me in my practice, free testosterone has been enormously useful. That there's a lot of men that we see who have classic symptoms of low levels of testosterone, of hypogonadism, but their total testosterone levels do not reflect it. And in many of those cases, the free testosterone will be low. And part of the explanation, as you point out, is that, a lot of the circulating total testosterone is bound to sex hormone binding globulin, SHBG. And from a study that we published, there's a huge variability from of SHBG levels in men. And many of the men who have what we might call generous or even elevated SHBG levels, there's no reason for it. Like, there's nothing that you can predict by looking at them. And so the free testosterone for us has been very useful. And there was a nice study, gorgeous study by Antonio out of the European Male Aging Study Group that showed that symptoms tended to follow free testosterone levels, low free testosterone levels, even more so than total testosterone. So I just put that out there. Yeah. We're almost out of time. I'm going to ask you one question here, which is that about the use of testosterone versus agents like Clomid in younger men and fertility. What do you do with, say, somebody who has been on testosterone itself and wants to have start a family within the next year or so?
I tend to use clomiphene first, mainly because it's cheap, it's oral, and also it's been made a lot easier because of the shortage of HCG. We find it very difficult to get in the UK, and again, this is also a Brexit effect because most of it's made in Europe, and we seem to not be able to get it for routine use in the UK. So that's made it easier. And I'm quite impressed with the effects of clomiphene. A lot of the patients don't expect it to be effective, but it certainly does get the testosterone levels up very quickly into the normal range. And they may need a bit of time to begin to realize what's happening. But if you give them about 3 months and tell them not to expect overnight miracles, I find it's highly successful in these groups.
Very good. Well, we've come to the top of the hour, and we have to conclude this. That was an outstanding presentation by Dr. Hackett. Thank you so much. I'm sorry we didn't get to all the questions, but I think what you've gotten here is a wonderful, not just overview, but actual careful dissection of the actual results from the testosterone trials by Dr. Hackett. Certainly what they show us is that some of the well-established benefits of testosterone therapy, and very reassuring data about the risks. You know, as Dr. Hackett said, medicine, we tend to really like these very large, very long studies about to assess risk of any medication. And those have not yet been done for testosterone. There is a large American trial going on now where we should have results about cardiovascular issues, hopefully within the next year. But all the data so far, as Dr. Hackett reviewed most of this, is really quite reassuring. And we have to use the data that we have and not always the data that we wish that we had. So with that, we're going to conclude here. I want to thank all of you for coming. And I want to thank Dr. Hackett for your wonderful presentation, and the AReA team and the audiovisual team and Bassans for sponsoring this event. Thank you all and have a wonderful day.
Thank you.